This is Walter Kemp dictating. This is Ischemic heart disease, part 4. So the beginning, this is our dog Raven to the right, who's a rescue puppy, and this is our cat Mochi to the left, who's not a rescue kitty. They're actually getting along pretty good this night. So lecture, Ischemic heart disease, part 4. There'll be one more after this, so there's 5 total. There are the websites where Dr. Hughes and I have USMLE questions, Twitter, which, like I said, should hopefully be doing maybe this weekend. I'll get around to it, like I've been saying. And then just remember, I'm a forensic pathologist. That's my area of expertise. But I just have a strong interest in general pathology, which I think keeps me knowing it on a very basic level, which I think helps me stay at the level the students need, which I hope is why I do a reasonable job teaching medical students, I hope. So, and I really enjoy teaching medical students. I hope these are useful. So here are my disclaimers. Pause the video, read it. If it's something that you don't agree with or applies to that, then stop watching the video. The videos I want to help teach people pathology. I just want to make sure everybody's watching them who should be watching them. And disclaimer number 3, same thing. If you don't agree with it, then don't watch the video. And in the bottom is my video I have posted of my teaching methods if you want to know the way I approach lectures and stuff like that. There are my references. We'll have a question at the beginning. So pause, read the question, and then we'll answer it at the end. Okay, so we're going to talk about complications of a myocardial infarct. So the acute myocardial infarct, these are some of the complications that you can have. So arrhythmias, and arrhythmias, it says, is one of the most common reasons for a out of the hospital death once a person's had an MI. I would assume once they make it to the hospital, then once they make it to the hospital, I think the most common cause of death is more congestive heart failure, probably because the arrhythmias can be controlled to some extent. So congestive heart failure can occur, cardiogenic shock, and it says this is the most common cause of in-hospital death. So to me, cardiogenic shock, congestive heart failure, there's overlap. Usually though, it seems like when you use the term congestive heart failure, implying more something more longer term, which could happen. So somebody could have cardiogenic shock if you infarct greater than 40% of the left ventricle. There's just not enough muscle there to heart to do it. It needs to. But at the same time, you could survive your infarct, and then later on, because of the injury that's been inflicted on the heart and everything like that, that you could just develop failure. So I guess cardiogenic shock would be acute failure, and then chronic failure would be later. You can also see right ventricular infarction. It says this is most common when you have an inferior septal infarct of the left ventricle, and then these are the ones that are more likely to extend onto the right ventricle, and I've seen that. The thing about it is you rarely have just an isolated infarct of the right ventricle. The heart can rupture. You get a myocardial rupture. You can also get papillary muscle. Oh, and sorry, the myocardium can rupture at the free wall, which is most common, and then you get a hemopericardium, which can lead to cardiac tamponade and death relatively quickly. You can also have a rupture of the septum, so you can get a left to right shunt. And then you can have papillary muscle rupture as well, so you get acute mitral insufficiency. And also you can just have, with the infarction, you can just have papillary muscle insufficiency because the muscle is dead, so even though it hasn't ruptured. Aneurysm can form when you have a transmural infarct. When it scars down, that can bulge out. Pericarditis, it can occur acutely because of the inflammation, and then Dressler syndrome, which occurs later, it may be something more autoimmune type related. Because you have necrosis, because you have that process going on, remember that thrombosis is part kind of the inflammation, kind of lumps together somewhat, and so you can have, as part of the inflammatory process, some degree of thrombosis. The other thing is that the myocardium is not beating the way it should be, and so it's also going to allow blood to pool, and you can get mural thrombi, which don't do much in the heart necessarily unless they're really big, but then they break loose and embolize, and that can cause problem. Then you can also have what are called infarct extension and infarct expansion, where the muscle actually bulges out, and I'll show you that. So with arrhythmias, some of the mechanisms, I guess the way I look at it is the heart's one big electrical system in a way, and it has to have communication. So if you have an infarct in it, you're going to put a block in that, and you're going to potentially set up an abnormal communication. That's kind of my simplistic way of looking at it. And so lack of perfusion of the cardiac myocytes accumulation of toxic metabolites. You're going to get that with necrosis and that and the abnormal blood flow, and then autonomic stimulation. The blood supply is there. What supplies each one, and obviously it seems like the AV node would be the most common, and most SA, AV, mostly applied by the right coronary. To the right of it, I just have the things. You have sinus brady, heart can slow down. You have sinus tachycardia. You have ventricular premature beats, ventricular tachycardia, ventricular fibrillation, and then potentially AV block. So congestive heart failure, cardiogenic shock. Like I said, cardiogenic shock is going to occur right away. Congestive heart failure usually later, but it's kind of the same idea, if you ask me, in that the myocardium is damaged to the point where it can't pump out enough blood to supply the body's need. And so they can cause acute problems or just over time. So my understanding is with cardiogenic shock, it's usually about a loss of about 40% of the myocardium or greater. And then the mortality rate is pretty high. And then congestive heart failure, you're going to get damage to the myocardium. That can lead to insufficiencies, can lead to arrhythmias and that, and can occur over time. So to the right of it, this person, the yellow, it goes from, this heart's actually flipped upside down. So the anterior is inferior and the inferior is superior. So you can see the yellow that basically corresponds with the distribution of the left anterior descending, all of the anterior, and actually all of the interventricular septum. And then you can see mural thrombi. I've drawn a little arrow too. And those are occurring there. And so those, if they stay put, will probably not cause that much problem. But if they embolize, can cause a significant problem, even a small one. And then chronic ischemic heart disease, when an individual has multiple episodes of ischemic heart disease and survives them, they'll get scarring, but eventually they're going to lose, they can eventually lose a significant portion of the myocardium, and then the myocardium just can't do its job. So here you can see the anterior septal to the top right, and then the inferolateral to the bottom left. So it's infarcts and at least the distribution of 2 coronary arteries. But you're going to get enough scarring and enough damage to myocardium that you're ultimately going to get to failure. So with congestive heart failure, that be basically what this would cause. You're just basically going to get some damage to the myocardium to the point where it just can't pump out enough blood. So what you're going to get is that you get dystonia exertion. The left ventricle is going to be the one that most likely fails, because that's the one that's going to have the ischemic injury. Remember, it's really uncommon to see ischemic injury to the right ventricle by itself. And so because blood then will back up to the lungs, you get dystonia exertion. The orthopnea, paroxysmal nocturnal dystonia associated with that, rowels because you hear them in the lungs, S3 on auscultation, and then usually because it's left-sided first, you won't see peripheral edema, no hepatosplenomegaly. When the congestive heart failure is due to episodes of ischemic injury in the myocardium. So rupture usually occurs around 24 hours post-MI to 7 days post-MI. Most, in my experience, are actually at 1 to 3 days. If you read the cardiovascular pathology literature, it's usually about 1 to 3 days. The location, as I said, it can be in the free wall, which will lead to hemopericardium. It can be in the interventricular septum, which leads to left-right shunt, or in the papillary muscle. And it says at risk, first MI, which I guess kind of makes sense when I think about it, because if you have an MI, there's going to be no scarring around it. So if they've had an MI before, they have some scar tissue, and it might be a little bit tougher for that to tear. And then women also. So I have a challenge if you just want to look at first aid says 2 to 7 days for papillary muscle rupture. It says 3 to 5 days for septal rupture and 5 to 14 days for free wall rupture. Okay, so it gives exact timing for each one, and it's different. 2 to 7 days for papillary muscle, 3 to 5 days for septal rupture, and 5 to 14 days for free wall rupture. So my challenge to you, and I can't find out if anybody does, unless you want to put a comment in, I'd love to see it. What is the source? I've never honestly in my search through literature and stuff like that been able to identify the source for that. So the rupture, so the top left, there's a hemopericardium. You see a hemopericardium. You can see the pericardial sac, and you kind of see this bluish tint to it. That's from the blood within it. And then the bottom right of it shows the corresponding myocardium, and you can see the tear very visible there. Tears can vary from basically the whole free wall is open, and you can see this tear in it to this serpiginous thing that just goes through and goes from the endocardial surface to the epicardial surface and causes hemorrhage. Papillary muscle dysfunction or rupture. I've shown you this image before, but in this case, the papillary muscle is dead. You can see it's yellow. So as long as it's insufficient, as long as it's dead, it's going to contribute to the possibility of acute mitral insufficiency. It wouldn't have to rupture, but it could. Aneurysm. So an aneurysm basically occurs when you have a transmural infarct and you get the fibrous scarring and that bulges outward. So they say that a true aneurysm is pathologically is something you're going to see much later, because you have to have the transmural infarct, you have to have the fibrosis, and then you have to have the aneurysmal. That being said, my understanding is, it makes sense, clinicians can actually see on imaging an aneurysm right away. Whenever the heart beats, it's going to push blood against that dead tissue and make it bulge out. And then when the heart relaxes, it goes back in, goes out, goes back in, goes back out. So on imaging, it could look like an aneurysm, but the pathological aneurysm would be something that is more of a late-term complication. And then here are mural thrombi. So like I said, you're going to have inflammation, and then part of inflammation, there's inflammation and coagulation have intersecting mediators, and don't occur in by themselves necessarily. So you get that as part of the inflammation associated with the necrosis of the cardiac myocytes, and then you're just going to get abnormal flow. And so both those are going to contribute to it. So like I said, if they stay localized, they could resolve, they could just resorb like that. But if they embolize, that's where the problem is. So a tiny little embolus in the carotid artery or the cerebral artery can cause significant pathology. This is a large mural thrombus in the chamber. So you can see just going from section to section to section there. You can see this large mural thrombus. Pericarditis. Right away, you'll see pericarditis, and it would be associated with a transmural infarct. So I'm trying to show us to the right side. You can see pericarditis. You can see this granular stuff on the surface to the bottom right there. And then the top left, it's shiny. The reason is because with the transmural infarct, the necrosis would go to the surface, and then you get inflammation at the surface, and that's when it causes kind of this fibrous deposition, stuff like that. So it causes sharp pain, and you can get a friction rub. You can imagine that rubbing against the pericardium. And then Dressler's syndrome is a pericarditis, but this usually occurs weeks after myocardial infarct. They think it might be due to an immune reaction to the damaged myocardium. Similar features, sharp pain. You can see an elevated erythrocyte sedimentation rate, which go along with some type of inflammation, and then pericardial effusion. So infarct extension, infarct expansion. So infarct extension is an increase in the size of the infarct, and you can imagine if the thrombosis propagates back, it can potentially increase the infarct. And then infarct expansion is where the wall that's infarcted bulges out. So if you look at this one to the right, the infarct at the bottom, it's really, really thin. You can see the septum is a little bit thin toward the bottom. The wall at the top there is relatively normal thickness. To the left side is probably normal thickness. But that thinning is like 3 days. So what happens is when you got all the dead tissue in a transmural infarct and the blood's pumping against it, like I just told you a while ago, it'll bulge out, and that makes it thin out like this. And it thins out like that. So there's no scarring or anything like that. So this was a license plate. I like to collect Star Wars license plates. I actually saw this one day driving, and I couldn't get a picture of it quick, and I was like, I'm never gonna see it again. And then one day I went to the grocery store to get something for lunch, and I just drove into a spot, and I like, there it is, and I got a picture of it. So for Boba Fett, of course. Okay, I've been told that on the USMLE they do want you to know rough timing of complications, so I put them in here. Cardiogenic shock, cardiac dysrhythmia, those should usually be like less than a day. The post-infarct pericarditis will go along with the inflammation, and rupture 1 to 3 days. 3 to 7 days, depends on what you look at, everything like that. Like I said, I think in the cardiovascular pathology literature, my personal experience, usually around 1 to 3 days. Robbins is more 3 to 7, which kind of makes sense too, because that's when you got the macrophages cleaning everything up, and there's not much left there, and the granulation tissue hasn't really started to be laid down yet. But at the same time, when it's infarcted, it could tear really easy because it's damaged. And like I said, first aid does have a timing for all those 3 of those separate. I just have not been able to find it in a literature search, and Love if somebody put a comment in there, gave me the article that came from. And then greater than 2 weeks, you can see a true aneurysm, the transmural infarct, scarring, and then bulging out, and then Dressler syndrome. So I'm just going to cover the lab diagnosis and treatment a little bit. So in the past, I think now mostly they just use mostly troponin I, but they're still using CKMB. When I trained, it was CKMB and LDH. But basically the idea is the same for all of them. It's you have damage to the cardiac myocytes, so it's going to release their components into the blood, and then you can pick those up. So creatine kinase, CKMB, is very important to get a ratio. The reason being is that CKMB is not specific for heart. You also see it in skeletal muscle. So here's my way of showing this. When you infarct skeletal muscle, you could put out a bunch of CKMB, but you're going to put out a whole bunch of CKMM. Whereas if you infarct cardiac muscle, you could put out a lot less CKMB, but you're going to put out hardly any CKMM. So in cardiac muscle, when that's infarcted, the ratio of CKMB to CKMM is going to be high. And in skeletal muscle, when you infarct that, the ratio is going to be low because most of it's going to be CKMM. So this is why the ratio is important. This is why just looking at CKMB by itself wouldn't give you as much information. You need that ratio. You need to know how much the other components are out there. Troponin I is the one that's now, as far as I know, the main one used. CKMB probably in certain scenarios. I still see it every once in a while, but they both rise very quickly within a couple of hours. The nice thing about troponin I is that it stays elevated for a while. So with CKMB, it'll drop back to normal. So if somebody was a week out, troponin I might still be able to identify that they had a infarct, whereas CKMB would not be able to. The other thing I've heard about troponin I is that you might want to ask your hospital, but I've heard it's very lab specific, and so the reference ranges for there are important. This is true for, as far as I know, for most lab testing. For reference ranges, you always want to make sure you're consulting your hospital's reference ranges, which are usually printed right there, because the reference range can vary hospital to hospital. So what's high in one hospital may actually be high in another hospital. Depends upon kind of testing modality and other things like that. Okay, so for treatment, they can potentially lyse the clot. And then with that, what you can see is if you lyse the clot and there's been ischemic injury, then you can see a hemorrhagic infarct. That is because the tissue is dead, and when the blood gets flowing to it again, it leaks out of the red blood out of the blood vessels, and you see extravasated red blood cells. So you see a hemorrhagic MI. So they can also use angioplasty, stents, which I think seems like mostly the treatment of choice now. Bypass as well too. At the top, these are stents. This individual has stents in place. You can see the little metal wires there, but it's pretty much completely occluded by atherosclerosis. At the bottom, the yellow arrow shows one of the ostia from the aorta, and the other ones show the saphenous vein grafts. So this will be what you see in cardiac bypass. Okay, so pause, answer a question, then we'll go through the answer. A 52-year-old male complains of pain in his chest while golfing with friends and that his arm hurts. He becomes short of breath and diaphoretic. On the way back to the clubhouse to call an ambulance, he becomes unresponsive. Of the following, what is the most likely mechanism of death? So that would be an abnormal cardiac rhythm. So this would be an individual who has an MI. That would go along with the chest pain and the arm hurting, shortness of breath, diaphoretic, and then collapses. So cardiac tamponade due to free wall rupture would not occur in that time frame. It's going to be it can occur less than 24 hours, but not in that short time frame. Dressler syndrome is something that occurs later. Acute mitral insufficiency could, but that could occur right away because the tissue is definitely abnormal. The muscle could be affected, but it would be something that probably is not going to cause them to collapse suddenly, whereas an abnormal rhythm would. And then mural thrombus would take some time to form. So once again, with reflection, just think back, look, what are 5 things that you learned from the lecture? I'm hoping I taught you 5 things. And then use this, and like I said, I don't put a summary there because it would kind of defeat the purpose. So just it's a really good teaching tool. It's in that Make It Stick. They took a student, used it, went from the bottom of the class to the top of the class using this one thing. So, okay, this is my kitty cat Loki. He went for a supervised field trip a little while ago and was outside checking out the backyard and everything like that. So I hope this lecture has been useful to you. Thank you.